Okay, talking about uveal melanoma, there are three parts of the uvea: iris, ciliary body, and choroid, and you can get a melanoma and an nevus in all three of them, and you can see the percentages here. So what I want to get across is the typical clinical presentation of the lesions. Starting with iris melanoma, typically it's lightly pigmented Caucasians in the inferior parts of the iris, and about 50% have a distortion, either ectropium uvea or distortion of the pupil. But this is not a sign of malignancy. This can happen for all sorts of reasons, and only in 50% you have it. Usually you have a velvety surface of the tumor, and the tumor is in the iris stroma, not in the pigment epithelium. It can be relatively flat, and if you do an OCT, you can see it in the stroma, not in the pigment epithelium. It's also important for your ultrasound examination. About 10% of iris melanomas are non-pigmented, and this is a typical classic presentation of a melanoma. Although it's a little pigmented, but in all non-pigmented melanomas, you usually find, or in almost all, some type of pigmentation on the outskirts of it. So usually there's some melanoma cells that are pigmented on the edges. But if you see something like this vascularized, it's very likely to be an iris melanoma. Another typical clinical feature is this is a bit out of focus, but what I want to focus on here. In a lot of cases, they start seeding on the iris surface and into the chamber angle. And if you treat them, it is not enough to just treat this tumor. You need to think of melanoma everywhere in the eye, clinically really a big problem in daily life. And this is the ultrasound. The ultrasound varies. In this case, it's a medium to high internal acoustic reflectivity, but what you can see, blood vessels in there, clear pulsations, and a Doppler phenomenon. So the iris melanomas are not like the uveal melanomas that you have a clear low internal acoustic reflectivity. They're usually a medium or higher reflective, so it doesn't help you in the differential diagnosis. And then you can have an iris melanoma without a melanoma. And these are classic in the glaucoma clinic as pigmentary glaucoma. It's not, because pigmentary glaucoma is bilateral. So you have a unilateral pigmentary glaucoma. Always think of an iris melanoma. And if you sometimes they are treated as heterochromia, iritis with glaucoma. No, heterochromia, the patient would have had a long history of it. So if the color of the iris changed over the recent year, please always think of this. You don't see a nodular tumor anywhere. It's just a diffuse iris melanoma. And if you're not sure, try to make pictures, and if you get old pictures, you can see this lesion before and now it's growing. They can grow very slowly, sometimes over 30 or 40 years. So, but give old pictures and you know it's an iris melanoma and not a nevus. Another thing to do with iris lesions, always look at the fellow eye. So if you see this, you're not quite sure what's happening. If you look at the other eye, this is iris freckles, and it's nothing to do with a melanoma. And this is not an iris melanoma. Always go beyond it, and if you sort of at the end of this talk, you know what the other clinical sign for this is. These red blood vessels there. So if you do an ultrasound of this lesion, what you can see, this is only the tip of the iceberg. And you've got a big ciliary body melanoma, which is the origin. If they're in the iris, in the ciliary body, where the bulk of the lesion is, this is what gives it name. So it's not an iris melanoma with ciliary body infiltration, it's a ciliary body melanoma with anterior chamber and iris infiltration. And the typical clinical signs for ciliary body melanoma are a sentinel blood vessel. This is like a guardian sentinel blood vessel over the tumor. It's episcleral. It's not in the conjunctiva. It's dipping down. And the other typical feature you can see here, anterior chamber infiltration. So whenever you suspect a ciliary body melanoma, you need to do your gonioscopy to look for that. A classic sign actually is very hidden, and this is a lens infiltration or lens indentation. So if you're really, really careful with your clinical examination history, one of the first signs of a ciliary body melanoma is it's a lens astigmatism. So the glasses change, half a diopter or diopter of astigmatism that wasn't there before, and that is the ciliary body melanoma pushing on the lens. And then can you lead to a cataract, unilateral cataract, if one eye, no trauma history, has a white lens, and the other eye has a clear lens, always rule out a ciliary body melanoma, otherwise it can be disaster during your surgery. So this is sentinel blood vessel, AC infiltration, unilateral cataract, you know already this is a ciliary body melanoma. And obviously when you look inside, you can see the big shadow of it, you can see retinal detachment with it, and always please look if these tumors are the choroidal or ciliary body, do the anterior segment ultrasound, you can see this tumor goes all the way up right behind the chamber angle. So this is ciliary body melanoma, not a choroidal melanoma. And again, you can see all this flickering in here, the Doppler. This is typical for a ciliary body melanoma, this vascularization. Retinal detachment. Coming to choroidal melanoma. What are the typical clinical signs of choroidal melanoma? An exudative detachment in medium to large size and lots of orange pigment over the surface, which you can control with your autofluorescence. That will tell you these patchy cow flecks, basically. This shape is typical. It's not that what you get from fluid. You have more like a starry sky appearance. If you have these patchy appearance, that's typical for the orange pigment associated with choroidal melanoma. And orange pigment varies. This is a rare case of a pigmented and non-pigmented choroidal melanoma. And you can see the orange pigment over the pigmented part, and you can see it over the non-pigmented part. It's not orange. It looks dark and brown. And to confirm it, do an autofluorescence, and I blend this over. You can see how this is blending over. So in non-pigmented parts, orange pigment is dark, is brown, is gray. And you use the autofluorescence to check for that. This is another case with two typical clinical features of a choroidal melanoma. You can see a second vascularization clinically, and this is the part that broke through Bruch's membrane. You can see how the base of the melanoma looks different to the tip. This is under Bruch's membrane. This is in front of Bruch's membrane. So they look dark under Bruch's membrane. They look non-pigmented in front of Bruch's membrane. And in this part, you can see the second vascularization. And it's a collar stud appearance. The collar stud comes from the breakthrough through Bruch's membrane. You can see it in the ultrasound. What's typical for these collar stud tumors that you have a difference in the low acoustic reflectivity in the bottom part and a higher acoustic reflectivity in the strangulated part, so to say. And you can see, again, this Doppler phenomenon pushing through here, typical ultrasound of a choroidal melanoma. You can make the diagnosis with that. Also, if you do the ultrasound, always think of potential extraocular extension. This is a flat tumor that presented, and look on the ultrasound, you can see this knob, and you have to distinguish it from the muscle you can see here. But if you follow it through with the ultrasound, this is extraocular extension. Typically, extraocular extension has a lower reflectivity than the main part of the tumor. Now, we heard already from Hibber in small melanomas, what does a small melanoma look like in contrast to a nevus? You've got these two classifications that you can use in daily life, and the two really risky risk factors are orange pigment and subretinal fluid. Subretinal fluid you check with the OCT, orange pigment, again, this cow fleck shape. This is with the autofluorescence, and you can see the exudation in the past of that tumor. In non-pigmented, again, same with the iris. If you have a non-pigmented lesion and you look for this cinnamon dust or so on the side, they're often non-pigmented melanoma. And the risk factor here, even on the small lesion, you've got a low internal acoustic reflectivity with a little Doppler phenomenon inside there. So although it looks like nothing, it's got almost all the risk factors for malignancy, and this is a biopsy-proven small choroidal melanoma. And finally, progression. Yes, if this is a 20-year-old, it's different, but this is a 50-year-old. You can see a progression on the pictures in just 11 days. So we always look for progression. And one last trick for daily life. If you're not sure, this is 2 years after this image here. I don't know, you can see there's a change in the orange pigment. There's a change in the drusen, but is this lesion growing, yes or no? Make your call. The last trick I want to share with you is your 3D OCT that you have in your Heidelberg. You do it, but you never use it. But look at this now, before and after. And with that 3D OCT, you can really nicely see progression in a lot of small lesions, which is a risk factor for malignant transformation. And thank you very much for your attention.
Do we have time for one small question? Okay, we'll move on. It's my pleasure to introduce Ranal Jamar, who is an ocular oncologist from Helsinki.